Thank you very much. Bonjour et merci. And that will be the only French I will speak, I promise, because it's a cruel and horrible thing that I would be doing to the French language if I said anything more than that. But thank you very much for inviting me here. It's a great pleasure to be here. And thank you. I'd like to thank you also for this title here. I'd like to thank you for the title, but it's quite long. And if I were to read the title out to you, I imagine that little red button would start flashing. But actually, it's a great title, and I'm really pleased to be asked to be talking about some of the issues that underpin some of the epidemiology that we've already started to hear about in terms of why dementia is such a problem and why it's such a problem now. But I'm also really pleased to be able to talk something about what we already know, how things have changed for the better for people with dementia just in the last 10, 15, 20 years. How also we can think about what we might do for the future in terms of improving things for people with dementia so that we can also provide whole health systems that are better at dealing with the challenges of the 21st century, the challenges of complex medicine, the challenges of people with 5 or 6 things going wrong with them at the same time, rather than one thing going on. And dementia, for me, is a powerful exemplar of that complexity, of that new medicine, of that thing that happens late in life when more than one thing is going on. So thank you for this. I'm from England, so I thought I'd bring you some weather. Now, I flew in yesterday, and I came in from a rainy and a rather unpleasant autumn in England, and I thought, well, if I'm going to Canada, at least it'll be colder there. At least I'll be able to think better of my own weather when I arrive, and it was boiling hot. So I was there in a kind of tweed jacket with a sweater and all sorts of stuff. So, but the weather. Why would I want to talk about the weather? Well, I think this is a great picture, because if you look at that, is the weather getting better or is the weather getting worse? Now, I don't know how optimistic Canadians are as a group. We could try it. But those people that are saying the weather's getting better, you're optimists there. This is a projective psychological test that I'm giving you here. And actually, you can look at dementia and you can think it either in terms of, my God, there are going to be so many people with dementia and we don't have any magic medicines to make it go away. What are we going to do? Oh, let's go and do something else because it's too complicated. Or you can look at the challenge of dementia and say, yeah, we know, we can predict that in the future there will be more people with dementia. We can predict that in the future we will know more about dementia, and we can predict that in the future we will be able to do more for people with dementia, even without magic medicines. Though it would be good if we had those as well. There are all sorts of reasons to be extraordinarily optimistic again, about what dementia can do for health if we can crack this problem. This is the next great challenge for health services and for health systems, and also for basic and applied research. This is the work that we haven't done. And the challenge for us is to do the work that hasn't been done in this next century, rather than keep on doing more and more on what we do know. And it's such a broad subject that everyone can bring something to the party in terms of understanding dementia. So in terms of challenges and solutions, I have 3 of them that I'd like to share with them. And the first thing is that we need to know much more about dementia. But again, turning that on its head, we already know much more about dementia than we did. These are the number of papers on Alzheimer's disease published by decade. In the 1960s, there was a handful of them. In the whole of the 1970s, just 290. In the 2000s, that's up to something like 40,000, and it's going to be 2 or 3 times that amount in this generation. Now, most of those papers are unreadable nonsense. I know, because I've written quite a lot of them myself. But there are within that fantastic new insights From the very basic of science, the very most basic of sciences about how our nerves work, right through to how to care for people at the end of life in care homes. There's a tremendous amount of knowledge that's welling up, knowledge that we didn't have 10 years ago or 20 years ago. This is a fantastically exciting area to be working at in research, but also in terms of treatment and also in terms of care. And we're starting to realize just how important dementia is as a priority. The reason why we have the G8 and we have the World Health Organization waking up to dementia is because it causes problems. This is the mean population attributable fraction in terms of disability and dependence, and we see dementia being right at the top of that list. It is already a gigantic problem for health systems. And what's really interesting is to see a gigantic problem where we have not done all that we can do. Because if there's stuff that we haven't done, that we can do that's helpful, and there's a lot of people there, then we have a fantastic opportunity to improve things, not only for those individuals, but for our health systems as a whole as well. And this is a representation of some of the data that we saw earlier, but it's making the point that dementia is a worldwide problem. These are data from 2009 showing that the numbers of people with dementia will triple by 2050, but showing also that it is, as the speaker said before, a problem not only for the developed world, but for the developing world. So here we have the figures, and we saw this graph before, but, backwards. So what we can take from this is that the massive increase in people with dementia, numbers of people with dementia, which is driven by our success. We have been absolutely brilliant at enabling people to live longer. That is a fantastic success in terms of the policies of countries, in terms of improving hygiene, in terms of health, in terms of public health, in terms of the work that has been done with infectious diseases in the developing world. In the developed world, it's a fantastic testament to the brilliant success that we've had in treating and helping people who have those things that used to kill people in midlife. So we've been brilliant at decreasing the numbers of people that are smoking and therefore stopping lung cancers and heart disease. We've been fantastic at treating heart disease and cancer. We have done in the last 25, 30 years remarkable things in terms of improving longevity for cancer, so that when you go and talk to people now over the age of 50 in the United Kingdom about what their most feared illness is, that only 10% of people fear cancer. 68% of people fear dementia. Because dementia is the thing that people are concerned about now. Because we can't do the things that we can with cancer and heart disease, that we have with diabetes, that we have with arthritis, with all sorts of things, that we can't do those things in dementia. I like this slide. This is a slide from the United Kingdom, from the United Kingdom Alzheimer's Society, and the growth of the voice of people with dementia. The growth of the voice of carers of people with dementia has been, again, remarkable in the last 10 years. And much of the good things that have happened can be attributable to people like the Alzheimer's Society in Canada, in the United Kingdom, in the United States, advocating, telling people of these problems, making people aware of them so that the system wakes up to this. And this shows, of course, the increase in the numbers of people with dementia. And they're very similar, I think, to the numbers of people that you'd find in Canada in many ways. And that increase is very similar. But the thing I really like about this is that it reminds you that for all of these gigantic numbers, there are people involved. There are men and women and families affected by dementia, either directly through the people with dementia having that illness, a devastating illness that causes a decline in your ability to think and reason, your ability to look after yourself and do things, your ability to communicate, all the things that we really love doing get affected and get affected negatively by dementia. But it reminds you that there are people and those families that are affected by that. And within those families, there are immense and fantastic stories of people coming to terms with these difficulties. It is not the case that life is necessarily miserable with dementia. It is not the case that life quality necessarily decreases as dementia becomes more severe. That's counterintuitive, but there are countless papers now that have shown that to be the case, and that's because human beings are brilliant at adapting to situations. We are brilliant at finding solutions to seemingly complicated problems, and we're brilliant at coming to terms with these sorts of illnesses. But if we don't get help and support, we can't generate good quality of life for people with dementia. So we, as health professionals, have an absolutely pivotal role, potentially, in enabling people to live well with dementia. I was involved in the development of the National Dementia Strategy for England, and that was the title, Living Well with Dementia. And we already heard that women are more affected by dementia than men, and women are affected in social ways in terms of looking after people with dementia as well as having dementia themselves. It's a particular set of problems that fall on women. The cost of dementia is remarkable. This is data from Alzheimer's Disease International, from their World Alzheimer's Reports, and what they suggest is that dementia already costs over $600 billion per year, which, if dementia were a company, would make it the largest company by turnover in the world, bigger than Walmart or ExxonMobil. If it were a country, it would be the 18th largest economy in the world. It would actually be in the G20 talking about whether dementia should be a priority. We have Canada there. Dementia is smaller in terms of size than Canada there, so that's good, isn't it? These are remarkable numbers. Now, everybody tells you that their illness costs a lot of money, but this really does. This money here is about half the cost of family members providing care, costed at the minimum wage in whatever country you might be looking at. And the other half is health services, and it's social care provided in terms of long-term care, things that are often given at the end of life. Dementia is already an extraordinarily expensive illness, and we have to ask ourselves the question, is it the case that that money is being spent well? Are there things that we might do earlier in the illness to enable people to have a better life with the illness, so that they need less long-term care, so that they need less hospital admissions, so that they live better with dementia and have more healthy life with their dementia? And this is data from the United Kingdom that compares the cost of dementia compared with the cost of other illnesses. And essentially, dementia costs more than cancer and heart disease and stroke put together. And we have to ask ourselves whether we have hitherto given the same policy priority to dementia and research priority to dementia as we do and have done for cancer and heart disease and stroke put together. The answer's no, by the way, But this is a potential. This is why there's a reason to do better here. This is, if there were no money associated with dementia, if it didn't cost society and individuals the amount that it does cost society and individuals, there would be little reason for us to make it a priority and do things. But because it does, then we should and we must. Here we have a dead white male, Mr. Alzheimer. The title of this, Ich hab mich verloren. Mrs. Augustita, she was the first person that Alzheimer wrote up as a case of Alzheimer's disease, and Ich hab mich verloren means I have lost myself. The personal impact of dementia on individuals is profound. It is a gigantic challenge for individuals and families. And, we are there to try and help that. In terms of pathology, we're starting to understand more about what happens. But this simple idea of the amyloid cascade, we'll be hearing later about biological advance in dementia. It's just a lot more complicated than that. So one of the reasons why we have gone so little a distance in terms of finding a cure for dementia is that some of our paradigms may have been too simple. We need to have a complex understanding of the things that lead from to plaques, to tangles, to having the clinical syndrome of Alzheimer's disease that lead from normal brains to brains that are anything but normal in dementia. This is a real illness. This is not a socially constructed disorder. This is something that is devastating in terms of brain neurological death in people with dementia. But we know more and more, and we will know more and more. One of the things that we have done with this information is that we've started to change the way the public thinks about dementia. And that's really important, because that talks about what people are asking for, about help seeking, as well as what we offer as health providers in terms of health provision. And one of the things that national dementia strategies can do is that they can help galvanize and help focus countries into improving the quality of care, as well as research, as well as prevention that people provide. And all over the world, people are starting to decide that because of the impacts of dementia, because of the immense potential to do better, that there should be a more coordinated approach to that. And that includes the World Health Organization with Margaret Chan, it's been said, talking about this being the next great challenge. The world is waking up to dementia as a priority. It is great that David Cameron led the G8 as it was, now the G7 in this. It is great that there's a World Dementia Council. It is great that dementia is at the very top of policy priority. Just go back 10 years. Where was dementia in terms of policy priority then? When I started at the Department of Health in the United Kingdom, I was responsible for older people's mental health as a whole and dementia. There was me 1 day a week and 1/56th of a civil servant. Okay? That's the size of the policy commitment to dementia at that point. And it's changed a bit since then. And that's brilliant. And that change is so rapid. We should be gigantically pleased with that change. We now need to, we've started a ball rolling. We now need to keep that ball rolling, get it rolling quicker, and start delivering things for people with dementia. And one of the ways we do that is by understanding the barriers to care, the barriers to help seeking, the barriers to help offering, things like the stigma of dementia, preventing discussion, that's changing. Things like the false belief that dementia is a normal part of aging. Yes, it's associated with aging, but it's not normal aging. It's, even when you get to 85, it's only 35% of people that have dementia. It is not an inevitable part of aging. And the false belief that nothing can be done. We can already do immense amounts to enable people to live well with dementia. Now, that may well be to do with education and support and good quality diagnosis, so that you give people information that enables people to live well with their dementia. Those sorts of things, rather than treatments, though we have treatments that are of modest symptomatic help to people with dementia. And we have the ability to prevent harms in dementia. There are things that we can do that will enable people to live better lives with dementia. There's already an immense amount that we can do to help people with dementia. And one of the things that has been done is public information campaigns. This is one from the United Kingdom, the Worried About Your Memory campaign, with clear, simple messages that enable people with dementia and their carers to know what to do. Many people suffer from memory loss as they get older, but if it starts to happen on a regular basis, it could be the early signs of dementia. If you're worried, see your doctor. A message not only to the public, but also to professionals in terms of allowing, facilitating, making it okay for people to come to you with these problems and making it okay for you to see that as a legitimate health problem. In Japan, Japan has just published its national dementia strategy, the Orange Plan. Orange, by the way, because that's a positive image of autumn, with the colour of trees going golden and those sorts of things. So, the Orange Plan. And it's remarkable. Japan is a great example because Japan has more older people than anyone else per head of population. It's the oldest country in the world. And so it's always had large numbers of people with dementia for the last 10, 15, 20 years. But it also had very low levels of good quality dementia care. There were the highest levels of physical restraint in care homes, for example, in Japan. And one of the reasons for that was that it was very difficult to talk about dementia in Japan, because the word for dementia was essentially a combination of idiocy and stupidity. That reflects the way that the concept had grown up in Japan. But if you have a culture where there is filial piety, respect for elders, then it's quite difficult to talk about dementia if you are essentially swearing about older people. So they changed it to cognition disorders, a neutral word, and within 5 years they now have, I think it's now over 4 million dementia friends in Japan. And people are talking about dementia. They're developing new services throughout Japan that enable people to live well with dementia. We can change things. And very briefly, I want to talk through diagnosis and treatment. So in terms of earlier and better diagnosis, for me, this is pivotal. And the problem that we have in most developed health systems is that only about half the people with dementia at most ever get a diagnosis. And when they do, it tends to be late, at times of crisis, when it's too late to prevent harm. And our challenge is to change systems so 70–80% of people get that diagnosis, and they get it at a time when it's useful to them. There's immense power potentially in dementia. You want to move from having the diagnosis late in the disorder to early in the disorder, so we can prevent crisis and enable good. And we are starting to get models that can show that it is entirely possible within our health systems for not very much money to create systems that actually make the diagnosis well, that communicated it well to people with dementia so it becomes a source of strength rather than a concern, and that help them to plan care and help them to plan for their future. And these are data from the United Kingdom and the development of the Croydon Memory Service model, which has informed both the UK and the Japanese dementia strategy, and which shows that such services can improve quality of life, decrease behavioural disorder, and can work for a whole population. And they can potentially work to save money, because doing it well costs less than doing it badly. You spend early on diagnosis in order to save later on in terms of long-term care costs. And that means understanding how to make diagnoses, and there's a discussion about how early we should go. So where are we in diagnostics? Is there a simple, quick diagnostic test that tells us we have dementia? There's a clue to the answer at the end of the line, by the way. We don't. It would be great if there were, but we don't. And also there isn't a screening test that will enable us to find a group of people with dementia, so screening isn't the idea. What we can do, though, is diagnose people with dementia, but it's a clinical thing at the moment. It's about balancing evidence and information. It's about talking to the person with dementia and their family. It's not simple, but it's important and useful. Tests can help us make decisions. They don't make the diagnosis for us. And we need to be careful about what is research and what is practice, because research is tremendously important for us to identify cases early and very early, and people who might go on to develop dementia, so that we can test out treatments that might delay or prevent dementia. But in practice, we want to know whether people have got it or not, and that's a clinical process at the moment. We have immense variation in terms of diagnosis across the United Kingdom, but there are some good signs. Since the National Dementia Strategy, the diagnosis rate of dementia has been rising. For me, this is the reason why you do it. It's because knowledge is power. This is Francis Bacon, the founder of the scientific method. And essentially, knowledge is power for people with dementia. We can turn people with worrying symptoms into people who know what's going on. Toxic uncertainty into empowered understanding. That's how we enable choice, self-efficacy, and quality of life. It revolves around diagnosis. And a final couple of thoughts on treatment. There's such a big agenda. There's so much to do in dementia. But let's just look into the acute hospitals. If you go into acute hospitals, something like 70% of people in the United Kingdom are occupied by older people. Maybe half of those have dementia. It's a predictor for all the bad stuff that happens to people in general hospitals and all the costs that are associated with that. And there are starting to emerge models where you make the general hospital a place that is friendly and understanding for dementia. You're seeing dementia as part of our job rather than someone else's business. And that can really help, saving money, improving, reducing lengths of stay, and improving the quality of care. Antipsychotic medication is another area where we carried out a report that showed that Canada started off this story by identifying this as a potential risk. Antipsychotics essentially cause an excess mortality in people with dementia. It equates to about 1,800 deaths per year in the United Kingdom in 2009. And using existing clinical governance systems, using the media to focus down on this, it enabled government to be able to say this is something within our existing systems that we need to address, and the numbers of people on those medications are decreasing in the United Kingdom, and they don't seem to be in many other countries. So, a final slide. This essentially summarizes what we need to do in dementia. Okay. So essentially, it's one of those things whereby it is not sufficient to do one thing. There isn't a single answer to this. You know, if you're going to join the circus, you need to be able to ride two horses at once. And that's what we need to do in dementia. We need to do cause research, we need to do care research, we need to do cure research, we need to provide better services for people early in dementia and late in the illness. And then we get a chance to change the weather. Then we get a chance to make the world a place where people with dementia are treated better. And that will be better for our services, because, as I said before, it costs less to do it well than it does to do it badly. And perhaps most importantly, what it would do is just make people, as they grow older, and their families, just a little less frightened of growing old, and less frightened of dementia, because it becomes like cancer, where we can do something about it. So that's the challenge. My last quote is, "The future is unwritten," a quote from Joe Strummer, the lead singer of The Clash. We get to write the future. This is the point. This is the great challenge. This is the time where we can make a difference, and everything that we do can make things better for people with dementia. So thank you very much.
Thank you so much for the nice talk. Just one question about the diagnosis. It's quite low numbers who actually get the dementia diagnosis, 40% if I remember right. Is that figure from UK, globally? I could guess that in the low-income countries is even much worse.
Yes. It's a problem throughout the world. There's a great report from Alzheimer's Disease International that looks worldwide. And if you go to the developing world, then you'll find that almost nobody gets diagnosed with dementia. The highest that we get in the developed world is about 45%. And that's receiving a diagnosis at any stage in your illness. So most people with dementia never know that they have it. Now, they know something's going on, and they may think they've got dementia, but they've never had that chance for we, as healthcare, social care, to actually provide them with the help that might have made a difference. And when those diagnoses happen, it's late. If they happened earlier, then we've got a greater chance of changing the path of individuals with their illness, so it becomes one whereby there are less harms that will happen to individuals. So yes, those are UK data, but they are very similar across the whole of the developed world. There's one place that I've been to where it's much higher, which is the Isle of Man. So the Isle of Man, which is a very small island off the coast of Wales, and they basically have quite a low turnover in population. They know everybody. They've had really good memory services that have been working for 10 years, and they know about 90% of the people with dementia that have dementia on that island, because they've basically just done it. It's perfectly possible to increase diagnosis rates. It's just difficult at the moment to do that because people aren't quite sure what the benefits and the harms are.
We have a question at the back.
Hi, I'd like to speak on two aspects, more operational. In the United Kingdom, did you develop the concept of integrated clinical care networks as a means of operationalizing your national strategy? Question one. Question two, you can't change what you don't measure. Do you actually measure the results of care and/or the results of the work? If you could speak on both of those.
No, and two great questions. So the first one of the problems about dementia, about integrated care systems, one of the problems about dementia is that it's a terribly disrespectful illness. It doesn't respect the divisions we've created between health and social care. It doesn't respect the divisions that we've made about what services will do and what families should do and what industry should do. It kind of breaks these boundaries, and we're not very good at delivering services that actually that actually transcend the boundaries that we have at the moment. So you do need to create systems in dementia that really help. So, for example, if you were to intervene early in dementia in the United Kingdom, that would be a health cost. But the money that it would save 5 years down the line is a cost to social care, which comes out of a totally different budget, a third of which is paid by families. So you have to be able to integrate things to make things work. And in terms of the measurability of outcomes, this is really what I mean partly about a 21st century medicine. It was very easy. It's very easy to do surveillance when your outcome is death, because we're quite good at measuring death. Yeah? We're quite good at measuring events and people breaking things and getting infections and all of those things. Now, there's a tyranny of the measurable. Now, it's much, much more difficult to measure quality. And we are at a stage where it is very difficult to measure the quality of care in dementia in particular. Now, it doesn't mean that we can't, but we need different sorts of systems to be able to do that. So developments and advances in patient-reported outcome measures in dementia that enable us with certainty to be able to get an idea of whether people are living better or worse with dementia overall are very helpful. Incorporating them into clinical systems is difficult. The example that I showed of the Croydon Memory Service is one service in which we did incorporate those and were able to show improvements in the quality of care.
We have a question at the back and then one over on the side of the room.
Thanks very much. I'm interested in your thoughts about prospects for prevention and delay of onset. What do we really know about preventing dementia?
I think that's an absolutely excellent question, and one that will be addressed in the next half hour by our next speaker. Prevention is tremendously important, I agree. And again, we'll have plenty of time to be able to look at that with much more crunchy facts than I'd be able to give in response to that. So perhaps we can park that and you can come back at the end of the next talk.
It's not much of a policy question, but it's, from a primary care perspective, it's quite relevant clinically that could relate to policy. And many people really hate the diagnosis of Alzheimer's, but are almost comfortable with the diagnosis of dementia. So I'm curious your perspective on the specificity of diagnosis as opposed to the overarching diagnosis from the point of view of promoting early sharing of a problem.
That's a really good question again. It's interesting. There is variation from country to country about the words that people are more happy to hear. There are people that I have told that they have Alzheimer's disease, and they say, well, at least I haven't got dementia. And vice versa. Alzheimer's disease is increasingly used in a lay sense to cover all dementias. And that's why in the United Kingdom we have an Alzheimer's Society, for example. And that's absolutely fine. In many countries, the word dementia is more pejorative than Alzheimer's disease. And I think that in France that's the case. And that's why in France they didn't have a national dementia strategy. They had a plan Alzheimer. And I think that, so there are differences culturally in terms of that. I think what's really important is that people have the diagnosis made. Now, dementia isn't a diagnosis. Dementia is a syndrome. The diagnosis is of the disease that's causing the dementia, be that Alzheimer's disease or Lewy body dementia or vascular dementia or mixed dementia or frontotemporal dementia or whatever. I think that people have a right, in the same way as when you have cancer, you don't necessarily need to know that you've got cancer, you need to know what sort of cancer you've got because, you can live your life better with that. I think that you need to know more than just that you have dementia. And I think that what we've shown is that there are services that are able to do that if you set them up to do it, and they could be in primary care, they could be in secondary care, they just need to have the right skills to be able to take people through, the difficult and complicated process of diagnosis, which includes investigations, which includes collateral history and all of those things, and then takes them through the difficult and complicated discussions about what that means. So for me, it's not about the word that you use. It's about the fact that you spend an hour talking through what having dementia and Alzheimer's disease means. And so, for me, you aren't doing your job well in terms of making the diagnosis of dementia if you don't spend almost an equal amount of time discussing what that means for the family and also planning what they're going to do in the future. Knowledge is power, but the way that we give that knowledge is tremendously important in dementia. And we know that from cancer. We know that from other disorders. We haven't necessarily known it in dementia. And the thing that people say is, well, there's so many of these cases around. How can we possibly spend an hour talking to each person with dementia? And you take a step back and you ask yourself, well, how could we possibly not design services that will give people an hour for a disease that is as devastating as dementia and with which people may live for 7 to 12 years? So it's an hour's investment of somebody who is comfortable about talking it through. The main resistance to doing that is generally in terms of practitioners who are uncomfortable with dementia rather than patients, because patients want to know what's going on and they know that something is going on. Certainty is better than uncertainty. The idea that ignorance is bliss just isn't the case in dementia. It's knowledge being power.
We have time for one more question. If there's one from the audience, I see the mic approaching someone.
I just had a question to do with the point you just made, that living with dementia is often 7 to 12 years. And what can you tell us about the causes of death of those with dementia? Is it always the same? Is it because of decreased brain function and causing respiratory and heart? Or what can you tell us about that?
It's, again, a really important question. So what determines death in people with dementia? Well, most people with dementia are really quite old. And people who are really quite old have lots of things going on. In fact, if you look at multimorbidity, then people with dementia are the group of people that have most other chronic conditions. So if you've got dementia, you've probably got heart disease, you might have diabetes, you've probably got arthritis, you're on 15 medicines, with 5 things going wrong at the same time. So the things that carry you off are often the other physical illnesses that you have. Now, what's interesting is that people with dementia seem to die a little earlier than people without dementia. And that's partly because people with dementia aren't so good at cooperating with the treatment regimes that we have. It's partly because treatments aren't necessarily offered to people when they are known to have dementia. And it's partly probably because dementia does have a mortality of its own associated with it. So if you live well and healthily with your dementia in terms of your physical health, you will in the end die of the difficulties of dementia and you'll become progressively unable to do things and you'll become bedbound. And that's where, excellent quality care in care homes or in people's own homes and palliative care for dementia is important. The short answer is people with dementia die of all the things that people die of.